This is Dr. Rausch, and welcome to this Introduction to Health Education. Now, health education is the foundation of nursing practice, and we look at it in relation to teaching, learning, and then the benefits to the healthcare system that come from learning. So, to begin with, teaching is an activity that is, and I quote, undertaken or initiated by one or more agents that's designed to affect changes in knowledge, skill, and attitudes of individuals, groups, or communities. So education and teaching emphasizes the provider of knowledge or skills, such as the teacher, which in case of nursing would be you. In contrast, learning emphasizes the recipient of knowledge and skills, the person in whom a change is expected to occur. And remember that learning involves change in how you think and how you feel and how you perform different activities. So how do people learn? Definitely best through active involvement in the teaching and learning process. But what someone hears is filtered through their past experiences, the social groups they belong to, the assumptions and values, level of attention and knowledge, and the esteem with which they hold the person who is the teacher themselves. So they're accepting information based on what they already know, what they believe, the culture in which they were raised, and how well they understand and relate to this information. Let's look at the nature of learning itself. According to Bloom, there are three domains of learning: the cognitive domain, which is about thinking, affective domain, which is about feeling, and the psychomotor domain, which is about acting. We're going to look at each one of these a little more closely. So let's review these three domains again. Cognitive learning is what you know factually and can discuss in a matter-of-fact way. Professional knowledge, the stuff in textbooks, it relates to your mind and the thinking processes. Affective learning is about the emotions or feelings or attitudes. Do you value what it is that you're being taught? If you don't value it, chances are you are not going to learn in cognitive or psychomotor learning. Affective comes first. Psychomotor learning, then, is what your body can do with what your mind knows. And for you guys, it's things like drawing blood, moving a patient, learning those professional skills. And we teach people to do those kinds of skills also. But these things are rarely learned without demonstration, coaching, and practice. So let's just look at the different levels within each domain. This cognitive domain refers to intellectual activities such as remembering, understanding, applying, analyze, evaluating, and then creating based on what you know. So you make use of that information when you're teaching someone like about their disease process or their medication regimen. Do they know nothing? Then we need to help them just remember what it is they need to know, memorizing things. Then we have to help them understand what that means and then to apply it to their activities. The affective domain, then, if you look at this, it's about receiving that information and responding to it. Do they value it, which we talked about the fact that valuing is key for people to make any kind of behavior change. It is very difficult to change deeply rooted attitudes, beliefs, interests, and values, and people need a lot of support and encouragement. And certainly we can't make anyone change that. And then psychomotor learning again. I like the first one is imitation. So actually just to watch someone else do a skill and imitate them. Then there's manipulation and precision, articulation, being able to not just do it, but to do it well and then be able to articulate or teach it to someone else. Naturalization means it becomes a part of you. And there are 3 conditions you must meet in terms of psychomotor learning. And the first one is having the necessary ability. This includes both cognitive and psychomotor ability. So if you have someone with Alzheimer's disease and can only follow one-step instructions, then you need to tailor your education plan to that. You have to have a sensory image of how to carry it out. So when you're teaching a group of women how to cook in a more heart-healthy manner, ask the women to describe their kitchen and how they'd actually go about the cooking process. And then they have to have opportunities to practice the new skills, particularly in the environment where they'll be performed. So we just looked at the domains of learning, or the nature of learning. Now let's look at the nature of change, how people are motivated to change and actually are able to do so. Now the health belief model is one of the first theories that address this particular issue. And it proposes that a person's health-related behavior depends on their perceptions of 4 critical areas. And perception is the operative word. So it proposes that individuals who perceive a given health problem as serious are more likely to engage in behaviors to prevent it from occurring. So it's perceived severity is the first one. Perceived susceptibility, if I could say that, are about people who perceive that they are susceptible to a particular problem. They're more likely to engage in behaviors to reduce their risk of developing a health problem then. Perceived benefits are that people are influenced by perceived benefits of taking action. So if they see there are perceived benefits, they're more likely to take action to change their behavior in a healthy manner. And for example, individuals who believe that wearing sunscreen prevents skin cancer are more likely to wear sunscreen than people who believe that it doesn't prevent skin cancer. The last one is perceived barriers, and their behaviors are also a function of those barriers to action. Barriers to taking action can include inconvenience, expense, danger, such as with side effects of a medical procedure, discomfort, such as pain, any of these things that are involved in engaging in the behavior. Now, if you look on at the model, you'll see those modifying variables, and they include characteristics such as age and race and ethnicity, and the perceived threat. Do they feel like there is a threat to their existence, to their life, based on this particular health issue? And the cues to action. And the model posits that a cue or a trigger is necessary for prompting engagement in health promoting behaviors. But the cues can be internal or external. Physiological cues like pain and symptoms are internal cues. But external cues can be like a reminder postcard from a dentist or a product health warning label like you would see in a package of cigarettes. And the last thing to look at is self-efficacy. Self-efficacy refers to someone's perception of their ability to actually perform a behavior or make the change. If you think you can make the change, you're more likely to be able to do that. So you can see how all of these lead to the likelihood of changing the behavior. Well, the health belief model looks at why people do or do not change. The trans-theoretical model looks at the process of change, how people change. Let's do a quick review of these 5 stages of change, but this is on a website for your review, and the link to the website is in the module on Blackboard. So we'll start with pre-contemplation, where people have no intention of changing behavior. And I'll just illustrate these stages by using the case of someone who has a substance abuse problem. So people in the pre-contemplation stage are not thinking seriously about changing and tend to defend their current substance use patterns. They may not see it as a problem, and they see that the positives or benefits outweigh any costs or adverse consequences, so they're happy to continue using. In the contemplation phase, then, they intend to change in the next 6 months, but certainly they may procrastinate. They're able to consider the possibility of quitting or reducing their use. They're kind of ambivalent about it. And on the one hand, this is considered an enjoyable, exciting, and pleasurable activity, but on the other hand, they're starting to experience some adverse consequences. Preparation is the next phase. They usually have made a recent attempt to change their behavior in the last year, and they're starting to see the cons of continuing as outweighing the pros and are less ambivalent about taking the next step. Usually taking some small steps toward changing behavior and believe that change is necessary and the time is imminent. Equally, some people at this stage decide not to do anything, but they're in that decision phase. In the action phase, they're actively involved in taking steps to change their using behavior and making great steps toward significant change. Ambivalence is still very likely at this stage, but they may try several different techniques and are also at the greatest risk of relapse. In the maintenance stage, they're available to avoid temptations to return to using behavior. They've learned to anticipate and handle those temptations to use and are able to employ new ways of coping. They can have a temporary slip, but don't see this as a failure. And then, of course, you have relapse. And during the change process, most people will experience relapse. Relapses can be important for learning and help a person become stronger in their resolve to change. Alternatively, relapse can be a trigger for giving up in the quest for change. But relapse is a factor in the action or maintenance stages, and many people who change their behaviors decide for a number of reasons to resume things like their drug use or return to old patterns of behavior. But research clearly shows that relapse is the rule rather than the exception. The teaching learning process is really the nursing process, just modified and focused on teaching and learning. And the 5 steps include identifying the person's educational needs and establishing those goals and objectives, and then, of course, selecting the appropriate teaching strategies or educational methods. And it all depends, of course, on the skills of the effective educator and, at the end, hopefully developing an effective health education program. So let's go to that first part of the process, which is to identify educational needs. And if you read through these different questions that you would ask to assess the learner, you'll see that they relate directly back to those theoretical models that I've given you already, the health belief model and the trans-theoretical model. We're looking at what their characteristics are and the literacy level. What are their needs for health promotion, risk reduction, or health problems? What do they already know, and what skills can they perform? Are they motivated to change unhealthy behaviors? And what are those barriers and facilitators? In a nutshell, one of the programs where the students were working with children is they asked them, what do you know? And then, what do you want to know? And then, what did you learn to evaluate?